Welcome to CardioCast for Friday, November 22nd. I'm Dr. Jim Dwyer. This week, we focus on important and practice-changing studies presented at the American Heart Association's scientific sessions held in Philadelphia. Why the ISCHEMIA trial could change the way you manage patients with stable heart disease. How new data from DAPA-HF will shape heart failure therapy in HFrEF patients without diabetes, and more. But first, thanks to all of you who've helped us make this podcast better by taking our short listener survey. We encourage those of you who haven't to complete the survey by following the link in the show notes. And now the news. The ISCHEMIA trial compared invasive versus conservative management for patients with stable ischemic heart disease. And the response to its findings at the AHA meeting was emphatic. Ischemia is practice-changing. Ischemia included more than 5,000 patients with moderate or severe ischemia. Study chair Dr. Judith Hochman of New York University reported the results. They showed that an initial invasive strategy plus optimal medical therapy did not top optimal medical therapy alone at reducing the risk of cardiovascular death, MI, hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest. The composite endpoint rates at 4 years were 15% with the conservative strategy and 13% with the invasive strategy. Nor was there a significant difference in the major secondary endpoint of cardiovascular death or MI, 14% with the conservative strategy and 12% with invasive management. And to the investigators' surprise, patients with more severe ischemia or more extensive multivessel involvement did not do better with the invasive approach. In patients who had had angina at least once a month, an invasive strategy did deliver significantly better angina control and quality of life than optimal medical therapy. But an invasive approach gave no quality of life advantage in patients who reported no angina within the past month at baseline. Dr. Alice Jacobs is the director of the Cardiac Catheterization Lab and Interventional Cardiology at Boston Medical Center. Given the findings, Dr. Jacobs says she'd feel comfortable advising patients without angina or with controlled or tolerated angina not to undergo an invasive strategy. The practice-changing DAPA-HF trial gave strong evidence that the diabetes drug Dapagliflozin cut cardiovascular death and acute exacerbations in patients with heart failure with reduced ejection fraction, even among those without type 2 diabetes. But a new analysis of the 55% of the trial's patients who did not have diabetes should seal the deal. Dr. John McMurray says the relative and absolute reductions in cardiovascular death and hospitalizations or urgent visits for heart failure were substantial and clinically important, and those benefits were consistent in patients with or without type 2 diabetes. Speaking at the AHA meeting, Dr. McMurray of the University of Glasgow outlined the primary findings from the patients without diabetes. In short, those with a normal hemoglobin A1C level at or below 5.6% had a 26% relative reduction in the study's primary endpoint. That's essentially the same response as the 28% relative reduction in events in patients with type 2 diabetes. Dr. Larry A. Allen of the University of Colorado was the designated discussant for the trial. He discussed the strength of the findings in an interview.
This is a particularly strong subgroup analysis, and the reason for that is that the investigators, when they designed the trial, they had this question in mind. So they really went out and got a population of more than 4,000 patients, and again, about half of them had diabetes and half of them did not. So rather than a very small subgroup, you're really looking at a large trial that has two large subpopulations. The other is that because this was a central question, when they randomized patients, they stratified that randomization by the presence or absence of diabetes. So I don't think this is kind of a post hoc look at an interesting finding that somebody dredged up. This is a hypothesis that the investigators put out from the beginning, and I think that these are very strong findings, and the statistical significance of the benefits in terms of the outcomes, even in the subgroup of non-diabetics, is very strong.
We'll be right back after this message. Downshifting to ticagrelor monotherapy after just 3 months of dual antiplatelet therapy with aspirin is a winning strategy in high-risk patients who've undergone PCI for non-ST elevation acute coronary syndrome. That's the key finding from a subgroup analysis of the TWILIGHT study. Researchers at the Icahn School of Medicine at Mount Sinai in New York reported the results at the American Heart Association meeting. Post-ACS patients who'd undergone PCI completed 3 months of dual antiplatelet therapy with ticagrelor and aspirin. They were then randomized to 12 months of dual therapy or to ticagrelor plus placebo. After a year, ticagrelor monotherapy cut the risk of clinically significant or major bleeding by 53% compared with dual therapy. And monotherapy came with no increased risk of ischemic major adverse cardiovascular events. And finally, the 2018 recall of generic forms of the antihypertensive drug valsartan exposed weaknesses in the recall systems for generic drugs in both the United States and Canada that caused many patients on the drug to fall through the cracks. That's according to a study of prescribing patterns in Ontario before and after the recalls by the US FDA and Health Canada that was reported at the AHA meeting. Pharmacist Cynthia Jakovicius of the Western University of Health Sciences in Pomona, California, reported that 90% of patients on recalled generic valsartan products switched to another antihypertension drug, but called the 10% for whom the study had no data concerning. She also said that ED visits for hypertension in the month after the recall spiked significantly by 55%, from a rate of 0.11% to 0.17%. The two health agencies issued voluntary recalls of generic forms of valsartan in July 2018, following reports of NDMA, a suspected carcinogen, being found in the products. Eventually, the recalls expanded to include valsartan and other angiotensin receptor blockers containing other contaminants. Dr. Jakovicius noted that there isn't really a good system or strategy for recalls in either country. Regulatory bodies notify prescribers and physicians, but they don't know which patients are on it. You can find these stories and more by visiting www.mdedge.com/cardiology or by clicking the links in the podcast notes. This week's contributors include Bruce Jansen, Richard Kirkner, and Mitchell Zoller. And CardioCast Cardiology News and MDedge Cardiology are edited by Catherine Hackett. Remember, you can find CardioCast via Amazon Alexa, Apple Podcasts, Pandora, or wherever you listen to podcasts. And if you like what you hear, please leave us a rating or review. And be sure to take our short listener survey. For MDedge, I'm Dr. Jim Dwyer.